Dear students, exams are near, so not much time left, and today I will want to discuss some topics which we don't study too much in detail, some topics which sometimes we don't even come across, and these are the recent topics which are not often asked, but definitely we need to have an idea about them. So I have cherry picked some IMP ones, some special types of sutures, some special things in general surgery that you need to have an idea about. All right. And of course, as always, if you have any doubts, you can always message me in the chat box. Yes, good evening, Navjot and Datish. Hope you guys can see me and hear me clearly. And in a few minutes, I will begin. All right. Okay. So those coming for my class for the first time, I am Dr. Amrit. I am your surgery educator on the Unacademy platform. There is an opportunity for you to get some scholarships on Unacademy. There is a MedMinds scholarship test. This is on 10th of June and it's on pathology slides. Definitely you should go for it. It's a free of charge test. And if you get a good rank, you will get some amazing discounts on Plus subscriptions. Also, there are some offers going on. If you take a 3-month plan, you get 1 month free. If you take a 1-year plan, you get 2 months extra free. You just have to apply my referral code, that is 10 surgery. Our platform has 2 kinds of plans. There is a Plus and there is an iconic subscription. Plus subscription gives you live classes, batch courses, a proper schedule to help you study, and iconic gives you benefits of Plus as well as Prep Ladder. Prep Ladder has recorded video lectures, handwritten notes, all those things also, but iconic minimum subscription is 1 year or longer. For all Plus subscribers, you can now ask your doubts verbally during class using the raise a hand feature. So it will save time and you can ask exactly what you want instead of relying on chatting. And MBBS students, this one is for you. There are some amazing 4-year subscription rates for Plus as well as for iconic subscription plans. And if you apply my referral code, that is 10 surgery, you will get 10% discount on top of this. And this is since Unacademy has started professional courses for first MBBS, second MBBS, third and final MBBS also. So throughout your MBBS journey, you can take benefit of these courses. FMG students, there is a batch course which is going to begin on 7th July. This is a 6-month course, and for next 2022 students, again there is a comprehensive course which is going to begin. NEET PG, there is a short revision course for high yield topics on all subjects. So these are some things you can make use of depending on the exam you are appearing for. And for iconic subscriptions, there is a limited time subsidized rate offer. You just have to use my code and you get all these discounts on the iconic subscriptions. All right, so now I'm going to begin the class, and this will be MCQ pattern. So please respond in the chat box, and whatever doubts you have, you can get them cleared at the same time. These are not clinical questions. These are questions of topics which are not very explored, which are a little new, maybe last 10 years, 20 years. Those are going to be the kind of topics I will be discussing for the next few YouTube sessions that I'm going to keep. So today I've kept general surgery. Tomorrow I'm going to cover recent topics in GI surgery, small bowel transplant, short bowel syndrome, newer staplers in GI surgery, those kind of topics. Okay, so that is the gist of what I will be covering. All right, so I hope you guys are ready. Let's try to wrap everything up in 1 hour with all the questions that I have lined up for you. They are not difficult, they are just of topics that we don't really study. Okay, all right, let's begin. Let's see if you can answer this. This question has never been asked, and when I was doing surgery residency, that time this was a very popular answer. This will be helpful for all exams. You will realize as we go along. Which of these is a hemoglobin substitute? 100% either in surgery or in pathology they ask something on blood products every year, including in NEET PG, as Siddharth is asking every year. Now they are not going to ask the same thing again and again, like half-life, those kind of things, or what is the temperature, they will go one step ahead. So they will now start asking you these kind of things. And let me tell you, I have never seen this being used. I have only read about it, and this has come in maybe the last 15-20 years. So you need to know about it. Most of you have answered a particular answer. Most of you have said B, some have said D. Okay, now I give you an easy way to remember blood products. Very easy way. Blood products are either going to be, when I say blood product, they are derived from the blood. They are going to be packed RBCs or FFP or pooled platelets and so on. All these blood products are actually derived from the blood. Remember to add to this human albumin. It's technically not a blood product. इसमें आ गया human albumin. When I say hemoglobin substitute, it's not a blood product. There are some things which are called blood substitutes. Now there are two kinds of blood components which can be substituted. Anybody can tell me? When I say blood substitute, what do I mean? So we always study blood products, but we never study blood substitute. What are the two components of blood which can be substituted or improved upon? So if in the exam they ask you blood substitute, don't confuse it with blood product. FFP, platelets, they are not blood substitutes. Yes, anybody? What are the two kinds of blood substitutes, or what are the components which require a substitution? One is over here, hemoglobin. So one is hemoglobin substitute and other is plasma substitute. Unfortunately, this is not how they gave us in the books. So many times we are not able to study this. We don't understand these topics. Hemoglobin substitutes are not very commonly used, but hemoglobin substitutes are those which act like hemoglobin in someone who is having iron deficiency anemia or hemoglobinopathies. So someone who requires hemoglobin and you can't give him blood or iron all the time, you can use these substitutes for short term, and they are of two kinds. One is synthetic and other is biotic. What are plasma substitutes? Anybody can tell me while we solve this question? So synthetic means it is a compound which works like hemoglobin. Okay, it does the same thing. When I inject it in the blood, it will do the job of hemoglobin. It will do the oxygen carrying capacity of blood. It will do the same thing. It will go into the lungs, take the oxygen, go to the tissue, release the oxygen, just like what hemoglobin does. So synthetic is this perfluorocarbon, PFCs. Biotic is, yes, anybody, what is this biotic? What is biotic? Biotic is genetic engineered hemoglobin. Genetic engineered hemoglobin. Where hemoglobin is taken from donors, it's not called a blood product. It is genetically engineered, like how they engineer insulin, and that can be injected also. These are not commonly used, which is why we don't study them too much, but these are things which are quite new, so you need to know a little bit about them. Plasma substitutes are what are commonly known as plasma expanders, and all of these are plasma expanders, okay, which are used in later stages of shock. So high molecular weight dextran, cellulose. You know, if you as an intern have seen any of these medications being used, chelfusin, polymerized gelatin, all of these are plasma expanders. So when I inject them, they will suck the fluid from the third space and increase the intravascular volume. These are technically what are blood substitutes. Okay, so there is hemoglobin substitute and there are plasma expanders. These are not blood products. Okay, so they work just the same way like hemoglobin. They increase the oxygen carrying capacity of blood. Biomimetic is recombinant hemoglobin. and abiotic are perfluorocarbons. All you need to know is they are injected as lipid emulsions. Yeah, hemaxil, absolutely right. That is a plasma expander. So they are injected as lipid emulsions and they do the same role as hemoglobin does. Okay, that's all you need to know about this little important topic. Okay, I'm sure everybody likes knots. Has any one of you seen this knot? This again has never been asked. Okay, so but you need to know how to identify this. It is a unique knot in itself. In the era of laparoscopic surgery, say in the last 20-25 years, these things have become very important. They have come at the forefront. So what type of knot is this? Is it a reef knot? Is it an Aberdeen knot? Is it a rotor knot or an intracorporeal knot? These are the only 2-3 things that the general surgeon will know and he will put this question on. So Siddharth asked, is this going to come in INI-CET? 100% INI-CET. And these are the kind of questions most students will know the answer of also. So you not knowing will be, it's going to hurt your ankle a little bit. And even if you don't know, if you can't identify this knot, it's so weird looking. There is some description given, loop, loop, loop with a tail. ये नहीं समझ में आया, you should at least be able to rule out some of the knots. You should have some idea about these knots. Okay, all right. So most of you have given the correct answer. This is a roder's knot. What is a reef knot? Yeah, and what is an Aberdeen knot? ये 3-4 नाम ही है जो अपने को आने चाहिए. And why have all these knots become important? Because in laparoscopy, all these techniques hold some benefit. Okay, when I do laparoscopic surgery, it's not very easy for young surgeons to go and suture from outside in. You know, with all the long instruments to go inside and do a bowel anastomosis. Not very easy. So they devised ways of making their life easy, one of which is this, which, yeah, okay. So a reef knot is also called a square knot. This is the knot that is used in open surgery. I will show you a picture of which. This has been asked many times, reef knot or square knot. Which knot is not square or not secure? Which is the insecure knot or the knot which is not square? Tell me that also. Aberdeen knot is a unique one. I will show you its picture. It is the terminal knot in continuous suturing. I will show you, don't worry. This also has not been asked. कभी नहीं पूछा इन्होंने Aberdeen knot, and surgeons use it very commonly. It's the terminal knot in continuous suturing. Yeah, absolutely right. The knot which is insecure is granny. Granny knot is insecure or it's not square. The name comes from, they say granny is insecure when the son gets married. Okay, mother-in-law is insecure. That is the story behind calling it granny. This is a roder's knot. Now I'll tell you a little bit about roder and intracorporeal. When I'm doing laparoscopic surgery, either I make the knots inside the body or inside the abdomen. That is called intracorporeal. Yes, last mein lapetna is Aberdeen, absolutely right. And if I'm not very good at suturing inside, what I do is I make the knot outside and push it in, like this one over here. So this knot is made outside with multiple loops. So I make 3 loops, I tighten it, and then I pass the knot inside. So this type of a knot is called extracorporeal knot. Extra means outside. All right, extracorporeal. So roder's knot is an extracorporeal knot used in laparoscopic surgery. Anybody knows where this knot is used in laparoscopic surgery commonly? What is it used to knot? ये knot का मैं करता क्या हूँ? So I make this knot outside, pass it with an instrument through the trocar into the abdomen, and then what am I tying with this Aberdeen knot? Commonly in laparoscopic surgery. Anybody? They will give you a picture of that. They will give you a picture of that surgery happening and this not being passed. So then you will say, oh, I have seen this somewhere. And this is something you must know. Yes, anybody? Extracorporeal Roder's knot is used in which GI surgery commonly to tie something, and you may get that image also in your exam. Nobody? Somebody? It is used for ligating the stump in appendectomy. Stump in appendectomy. I will show all of these, don't worry. सारे बताऊंगा. So first let us quickly finish this part, laparoscopic knots, which are of two types. One is which I do inside the body, intracorporeal, which requires skill. The surgeon has to be skilled. And then there are extracorporeal knots like like Roder, which if I can't do knotting inside, I make the knot outside. I हाथ से मान के pass it with the instrument like Roder's knot. Now how do I use this Roder's knot? It's very simple. If I'm doing appendectomy, okay, this is the appendix, let's say, what I'm going to do is I will take this loop from outside. ऐसी होती है loop that I have made. You can see over here. It looks like this. So this is the loop with the thread. I push it inside with an instrument inside the abdomen, and I put it on top of the appendix, and then I pull it all the way down to the base like this, and then I tighten it. So when I tighten it, the base gets ligated, and then I cut the base of the appendix. This is how a Roder's knot is used. So it's like mala penana, putting the garland on the neck. The knot is put like a garland on the neck, and then it is tightened. So when I tighten it, the base of the appendix gets ligated, and then I cut the extra thread. Are we clear about this? This is how you will use the Roder's knot, extracorporeal knot, in laparoscopic surgery. It can be used in other places also, but commonly used in stump of appendix. Okay, this knot we had discussed. This is the square knot. I don't need to spend too much time. The square knot or the reef knot or the secure knot, I am not going to spend too much time on this. How do you identify? Both arms go underneath or both arms go above the crossing thread. Okay, and in granny knot it is alternate. One is going above and one is going underneath the crossing thread. एक ऊपर से जा रहा है, एक नीचे से जा रहा है. That is granny or insecure knot. And this is surgeon's knot. In surgeon's knot, you take 2 throws. So you get 4 loops like this. Because you are making 2 throws, you get 4 loops. That is surgeon's knot. And this image again never asked. This is Aberdeen knot. Last mein lapetna is what Vineet said. That's what it is. So first I do continuous sutures. Then when I reach the end, I just pull it inside like this and I tighten it. So this is Aberdeen. Have a good look at this. They have never asked this. Every time they are not going to ask you square knot or reef knot. They will ask you Aberdeen knot or Roder knot. If they ask, hopefully you will say, yes, I was right. Okay. This is, if you ask me, the most important question of the day. VVIMP. This is very new. Maybe last 10 years. So suture materials, we all know. This is a different kind of suture material. ठीक है, ये commonly use नहीं करते. It has some property which is different from the conventional suture materials. So you need to know this suture material. And I am asking you the false statement. Knotting is not required. Can be used for suturing rectus sheath. Longer length required. Available in absorbable and non-absorbable materials. Quite a few of you have jumped to the answer, which means either you know it or one person is following Raksha and then the others are following the same suit. I hope not. What do you call this suture material and what is unique about it? Yes, fully. If you look closely, I hope you are viewing this on a desktop and not on a hand device, because then you will get a clear picture of what's going on over here. This is not a normal suture. If you see this suture, it has these spikes on opposite sides. It has all these spikes. If I look from the side, I'll give you an orientation. This is the suture. It has spikes like this on opposite sides. They are there throughout the length of the suture, almost. Yeah, what is the suture called? Suture with these spikes. बहुत ही नई चीज़ है. नई means 10-15 साल. When I was in residency, this had just come. Excellent, Gopika. That's an amazing one. This is called a barbed suture. Please don't mistake barbed suture. It's different from braided suture. They are not the same. This is barbed. It has barbs. You know what a barbed wire is? Like if you're going to a gated community, or if you're going at the border, then they put those barbed wires, so that you don't कोई चढ़ के ऊपर नहीं चला जाए. So these things mimic those barbed wires. That's why it's called a barbed suture, not braided. Braided is polyfilament. This is barbed. What is the advantage of this? Yeah, dangerous looking, very dangerous looking. So the advantage of this is when I go through the tissue, the suture does not go back. The suture remains in place. So when I take a bite, it will remain over there. It won't go back. And because it won't go back, I don't need to knot this suture. Every suture I take, I have to make the surgeon's knot. 2 throws tight, 1 throw tie, 2 throws tie. वो नहीं करना पड़ता. Once I go through the tissue, it is secure. I just have to cut the needle at the end. That's it. So knotting is not required. It can be used for suturing any hard tissue. So yes, of course, it can be used for suturing rectus sheath. It comes in absorbable and non-absorbable forms. Yes, what is this one? This is absorbable or non-absorbable? The one that you see. What would you call this? What barb suture does this look like? While you answer that, longer length required. This is false. Since I am not having to make any knots, not knotting, no knots, I require less length. Because initial 2-3 centimeters are lost when I make the knot. वो knot में थोड़ा suture material lose हो जाता है. So I need less tissue length and less suture length if I'm using barbed suture. Non-absorbable. Why do you say which non-absorbable is this? Barbed what? Okay, you are saying non-absorbable. Which non-absorbable suture is this? This is barbed proline. Okay, it's blue color ka na? This is barbed proline, but it can come in absorbable ones also. Barbed PDS bhi hoti hai, which is a shade of purple. That is barbed PDS. So whatever monofilament sutures are there, they come in barbs. Commonly proline and PDS. They are the ones which have barbs that I have used. We use it when I'm doing a mesenteric closure in hernia surgery, in gastric bypasses. We use these barbed sutures, so you don't have to throw any knot. You just go through and through, and that's the end of the story. If I have to do a long suturing, I can use barbed suture. Fast ho jati hai. Okay, don't confuse it with this. This is polyfilament, okay, or braided. This is not barbed. Polyfilament or braided, and this is monofilament. Polyfilament like Vicryl, Mersilk. The advantage of these sutures is they have poor memory, and because they have poor memory, they have good knotting. The knots hold very well because they have poor memory. Monofilament, nylon or ethylene, PDS, proline, they have good memory. And remember, good memory is a bad thing. Good memory means the loops don't become straight. The loops of the suture will remain loopy and it gets entangled. So they have good memory, but good memory is a bad property of these sutures. Okay, that's all you need to know about these little itsy bitsy things. Now let us try to identify this. This also they have never asked. It's a very popular image, but very popular image. I'll give you a clue. This device is used in lap surgery, all laparoscopic surgeries. What is this device? Is it a light source, camera source, CO2 source, energy generator? And these images are there online, so it's very likely that you'll get an image of this kind only. There are these few companies whose images are freely available. उनमें से एक आपके एग्जाम में आएगी. Okay, today you guys are really on a roll. I think you are very well versed with recent topics. Tomorrow I will put very hard recent topics. I think general surgery, the recent topics आप लोगों को आ रहे हैं. Most of you are able to answer. So good job. This is a carbon dioxide insufflator. Now, what is a carbon dioxide insufflator and how is it used? When I'm doing a surgery, laparoscopic surgery, I have to push CO2 inside the abdomen. Okay, so first I put a trocar inside or a Veress needle and then I connect it to a CO2 tube. So there is a tube connected to the trocar. That tube is connected to this device. So from this device, the carbon dioxide will go through the tube into the abdominal cavity. Does this device produce carbon dioxide? Should I call it CO2 source or should I call it CO2 insufflator? Insufflator means through the air. Is it the source of CO2? Or is it only going to do what is called as insufflation, which is a weird English word? Does it produce the carbon dioxide, this little machine over here? Acha, how do you identify this? It says pressure, it says flow. So low flow, high flow. Flow of what? Flow of gas. Okay, flow of gas. So of course it has to be CO2 insufflator. Light source should have some reading about light magnification, strength of the light. Camera source करके कुछ नहीं होता. There is nothing like a camera source. An energy generator is going to have that yellow and blue buttons. Yellow button, blue button. Yellow is for cutting, blue is for coagulation. You see that, you know it is an energy generator. This, yeah, absolutely right. This is not a CO2 source. It does not produce CO2. Then where is the CO2 coming from? All this does is it monitors how much carbon dioxide will go inside. How much will go inside? What abdominal pressure will it produce? How much will be the flow? 12 liters of CO2 per minute is what it is going to permit at this point of time. Okay, if I want, I can make this 13, 14, 15, 16, how much ever CO2 I want to flow, it will allow to flow. So this is going to be a CO2 controller. Let's put it like that. Let's make our life easy. It's not a source of carbon dioxide. So what is the source of carbon dioxide? आ कहाँ से रहा है? To put it in the abdomen, 12 liters per minute. 12 liters per minute in a laparoscopic surgery, 300-400 liters of CO2 is used depending on the time or how much time is spent in the surgery. You use 200, 300, 400 liters of carbon dioxide. So where is the carbon dioxide coming from? Since this is not the generator, this is just the controller. It's like a filter. It will filter how much carbon dioxide should go at what speed, at what rate. Yeah, absolutely right. So behind this, if you go to any OT, there is going to be a carbon dioxide cylinder. जैसे oxygen cylinder होती है, there will be a carbon dioxide cylinder, big cylinder. अभी कोरोना के टाइम पे everybody was keeping oxygen cylinders. So there will be a CO2 cylinder which has the storage which you get from industries or petrol pumps, wherever it is produced. So you buy the cylinder and it is kept in the OT, and from that cylinder it goes to this insufflator, and from the insufflator to the abdomen. This is one way. Other is, some hospitals have central carbon dioxide through pipes. So they have pipelines. Like the hospital that I work in Mumbai, we don't use cylinder, we use central supply. So there is a pipe. If you go to any OT, there are pipes. Carbon dioxide pipeline, oxygen pipeline. Oxygen pipeline is used by anesthetists. Their machines use oxygen to give to the patient. So again, that oxygen is not produced, it is coming through the pipe. So through this pipe there is a CO2 pipe which is connected to this insufflator, and then the carbon dioxide is thrown. So don't get confused by the usage of these kind of things. This is not a producer. They will give you, identify the incorrect statement about this instrument. It is a CO2 source. Tatesh will say, yes, it is a CO2 source. It is not. It is a CO2 controller. It does not produce CO2. What is this image? Stork. And what is this image? I already gave you little clues about these, but now you can tell me what is the first image, what is the second image. If you want, I will zoom in also. Thoda sa. You can see it. What is the first image and what is the second image? I have zoomed in a bit. Jaldi jaldi chalo. We need to finish whatever questions I have lined up for you. Yeah, what is this first one? What is this second one? You can get some clues of the things written. ऐसी ही image आने वाली है. Okay. Now I will zoom out. Yeah. Yeah, absolutely right. This is energy generator or energy source. You can call it whatever you want. So this generates it. It is actually generating. You can see yellow. You can see blue. So this is monopolar. Yellow. This is monopolar. This is bipolar. बाइपोलर में खाली ब्लू आता है, बाइपोलर में दोनों नहीं आते हैं. You don't get cutting and coagulation. Bipolar is only coagulation. I told you, na, yellow is cutting, blue is coagulation. Of monopolar, it's written over here. And bipolar is the next connection. Yeah, first is light source. Excellent. So this is light source. Both of these are sources. Alright, so a light tube will be attached to this, which will be attached to the telescope, which goes inside the body. So the telescope will have some illumination through this light. Every endoscope or laparoscope has to have these three fixed components. One is a visual component. Okay, that is your fibers. One is the light component, and one is the gas component to insufflate. Okay, all these three things have to be there for any endoscope. Alright, so there has to be a light attached to it. वरना अंदर दिखेगा कैसे? Otherwise, like proctoscope, you throw light from outside. Only then you will be able to see. When you go inside the body cavities, there is no vision till you throw some external source of light. Okay, so this is your light source. How do you identify? इस पे लिखा है HD LED. You know what is LED? So it's an LED light source. The light sources which are used are usually LED, or I think it's xenon, neon or xenon, one of the two. Neon जैसे light bulb होती है, I think they use xenon, I'm not very sure, but the one commonly used is LED light source. So LED is the source of the light. Okay, let's move on. What is this device? It's a very peculiar device. This has been asked before. This is a PYQ. This is not new from me. So this ये पहले पूछा है. What is this nice looking बड़ा सा tube? You can see its size is also written over here. A word of caution: if you see an image which you have never seen, which you cannot identify, try to match it to the options, go retrograde, and try to read the calibration. 90% of the times the calibration will give you the answer. Trust me, I've spoken about this in the images of investigations, manometry or 24-hour pH study, all those. उसमें समझ में नहीं आता ना कि क्या हो रहा है. All colors are happening, we can't make out what's happening. Read the calibration. Many times the calibration will give you the clue. So here this is 20 French, it's a tube in French. Then you see the length. See what length is written over here. Anybody can tell me what is the length of this tube? It's written over here. You can read the calibration. What is the length? Quickly. Then I will zoom out. Yeah. So this is 20 French, but what is the length of the tube? Yes, it length पढ़ के ना you can rule out some of the other options just by reading the length. Okay. So yeah, you've still not given the answer of what is the length. Nonetheless, a central venous catheter, usually it is triple lumen. नहीं दिख रहा, ऐसे मत बोल यार, बड़ी clear image है. It is usually triple lumen. It can be single lumen, no doubt about it. It's not as stiff. It's not going to be 20 French. 20 French is very mota. That is bigger than a Riles tube. Nor will it be a Swan Guns catheter. Nothing. Too short. Your doubt should be NJ tube or PEC tube. What is the length of NJ tube? What is the length of NJ tube? Nasojejunal tube. So the answer here is PEC tube. I'll tell you, इस पे लिखा हुआ है 15 centimeters. It's written on this 15 centimeters. And NJ tube का length जो आप बताओगे, it's much more. What is the hallmark of a PEC tube? It does not mimic anything else. If you ask me honestly, there is nothing that looks like a PEC tube. It's one of a kind device. The hallmark is this. This is called internal and this is called external bolster. Bolster means this is the part which will keep it hitched to the stomach. This tube goes inside the stomach. The internal bolster will remain inside the stomach. Nasojejunal tube in an adult is usually 120 centimeters. अच्छा, nasogastric tube की भी length बता दो. Nasojejunal tube, the usable length is 100 to 120 centimeters. It comes in different sizes. या 100 होगा या 120 होगा. Commonly used 120 centimeters. Nasogastric tube की क्या length होती है, जिसको हम Riles tube बोलते हैं, which is actually wrong. It's not Riles tube, but okay. What is nasogastric tube का length? इसका तो लेंथ सिर्फ 15 centimeters है. The hallmark is this bolster. This is what you need to identify it with. This is not seen in any other feeding tube. Nasogastric tube, nasojejunal tube, no other tube for feeding will have a bolster like this. This is a unique to PEC tube. Yeah. Nasogastric tube length, come on Natesh, Gopika, Vineet, 100 centimeters. Absolutely wrong. It's not 100 centimeters. The usable length is half of this, 60 to 70 centimeters. Half of this, 60 to 70. When you'll see the Riles tube ना, उस पे marking होती है. Marking is usually 40, 50, 60 और 50, 60, 70. जैसे इस पे marking है, उस पे सिर्फ 50, 60, 70 marking होती है या 40, 50, 60 marking होती है. That's it. It usually for stomach you need to put in an adult 50-55 centimeters. Utne mein it is inside the stomach. If you want to put it in the duodenum, maybe 65, little bit. The usable length is 60 to 70 centimeters, half of a nasojejunal tube. Alright, so what I was trying to show you was this part, the internal bolster, and this part with which it is fixed to the skin called the external bolster. And these are the feeding ports. Fine, there's a feeding port, there's an inflation port, अलग-अलग type के PEC tubes आते हैं, that's fine. What is the life of a PEC tube? For how much duration can I keep a PEC tube? For what duration can I keep a PEC tube? Days, weeks, months, years? For what duration can I keep a PEC tube? What is the life? Anybody knows? Any idea? Means why do I put a PEC tube where I can simply put a nasogastric tube, non-surgical? This is sort of surgical. You know, you have to do endoscopy. A patient requires some kind of anesthesia, at least sedation or local anesthesia. Not very easy. Expensive device, requires surgical skills or an endoscopic skills. So not very easy. So why do I put it? What's the advantage? It can be kept for 2 weeks. No, it can be kept for several months. Depending on the indication, it can be kept for several months. If the tube gets blocked, say after a few weeks, because I am giving him feeds, the tube gets blocked, I can simply change the tube. Change the tube means non-surgical. Just remove the tube, like I've remove the Foley's catheter and put another Ryle's tube or Foley's catheter. A new tube can be put in place. Okay, a new tube can be exchanged. You don't need endoscopy again if it is done after a few weeks time. So it can be kept in place for many months. It is for people with long-term neurological problems who can't feed, who have swallowing problems, head injury patients. उनके लिए अच्छा है. You can use to feed them for several months. Okay, this is also PYQ. I won't spend too much time on this. This is a AIMS PYQ. Also NEET PG PYQ. So there is a wound on which this kind of thing has been put, quite new, quite nice. It really works, trust me. This really works on bad wounds. How does it help in the wound healing? Negative pressure, positive pressure, sponge pressure, foam therapy. Bolsters don't cause any problem. No, see, once the tract is formed, like if the tube has been there for say a month and then it gets blocked, a tract is formed. So now when I remove it, it's not that the stomach will sink back inside, it will remain in place. So I can remove it and put a new one. Kabhi na kabhi to nikalna hai na. So if I give it a jolt, the bolsters come out, nothing happens. It only helps in retention in the initial period till the tract, a mature tract is formed. That's it. So yeah, this is negative pressure wound therapy. This is also called VAC dressing. VAC stands for vacuum assisted closure. Okay, this is also called vacuum assisted closure. So if there is a non-healing wound, which lot of slough, lot of discharge is not healing, I can apply this VAC. So VAC में क्या करते हैं? They clean the wound. They put the sponge. The black thing is the sponge. They put a tube on top and they seal it. So when they seal it, this tube is connected to a VAC generating machine or a negative pressure generating machine. It generates a negative pressure 125 mm of Hg. So it keeps sucking, and it's a battery operated or electricity operated machine. It keeps generating negative suction. So whatever edema, exudate, whatever is there, it gets drained into the machine. It can be kept for a few days to weeks depending on the indication. And once every few days or weeks, what I do is I stop the vacuum, remove the dressing, check the wound. If the wound is healing now, the job is done. If it's still not healing, I reapply it, but then I have to apply a new dressing. Okay, then I have to apply a new dressing. But that's about it. This is going to hasten wound healing. Okay, it's going to hasten wound healing. This is the machine to which generates the vacuum. It has like a collecting canister into which whatever exudate is there gets collected. And once the wound is healing, then you can decide, maybe you can put a skin graft. But how does it work? Drains the exudate, drains the slough, promotes local blood flow with the help of the negative suction. Clear? Okay. This is a very popular image that you need to identify. And I can predict what they will ask on this image next. So what device is this? Is it a Wim Silverman needle? Is it a TrueCut biopsy gun? Is it a Veris needle or a Jamshidi needle? Contraindicated in malignancy. What is contraindicated in malignancy? Yeah. What is this device? Nice looking. Has a spring inside. Has some knobs over here. Nice long thing. And it has a very unique tip. I'll show you the tip in the next image. इसमें नहीं समझ में आएगा. For all you know, the image that they will give you in the exam, they will focus on the tip, which you need to know. There is something unique about its tip. Yes, this is not a googly image. Means if you overanalyze it, you can make a mess of this question. Satish is saying varies. Gopika is saying varies with a question mark. और कोई जवाब? Vineet is saying true cut biopsy gun. Valve is the clue. Okay, what about the spring and the red ball inside? Okay, no problem. Understand, any biopsy gun, if you see any biopsy gun, it should have some buttons to perform the biopsy. So the TrueCut biopsy gun has a pink button or a green button. When you press the button, the knife goes ahead, takes the tissue biopsy and comes back. Alright, so this is not a TrueCut biopsy gun. All these are Wim Silverman needle, Jamshidi needle, they are all bone marrow or liver biopsy needles, not very commonly used. This is Veris's needle. The hallmark is, as Datesh correctly said, there is this adjustment valve. This is unique to Veris needle, and this is the inlet for the CO2. So earlier I showed you carbon dioxide insufflator with a CO2 tubing. So when I do the surgery, the first thing that I do is I put the Veris needle. Either I put it in the umbilicus or I put it somewhere over here in the left hypochondrium. I put the Veris needle like this, and then to this I attach the CO2 tubing, which is fixed to the insufflator, CO2 insufflator, the first image that I showed you. So the CO2 will go through this inlet into the abdomen and the pneumoperitoneum is going to be created. The question that they will ask you is, what is the maximum CO2 that can flow through the Veris needle? Because it's a thin needle. The image that I showed you earlier of the CO2 insufflator, I'll show it again. You see how much flow was happening at that point of time. You see, pressure 15, flow was 12 liters per minute. So the machine is going to throw 12 liters of CO2. But how much of carbon dioxide will the Veris needle, being as thin as it is, allow to enter the abdomen? So what is the maximum CO2 that can flow through the Veris needle during pneumoperitoneum? Excellent, Gopika, that's an excellent answer. 2.5 to 3 liters per minute. ये कभी नहीं पूछा है, ये पूछेंगे because all surgeons know this. All general surgeons are doing this surgery, they are using Veris needle, so they know this. And where do I insert the Veris needle commonly? Either the umbilicus or this area. What is this area called? Left hypochondrium, about 2 finger breadth below costal margin. What is this area called? Where I put the Veris needle during laparoscopic surgery. What is this called? Absolutely must know. Whose point is that? Whose point? Yeah, Palmer's point. Okay, so one of the common sites for putting the Veris needle, left hypochondrium, 2 finger breadth below the costal margin or 2 inches below the costal margin, Palmer's point. ये नाम याद रखना. Okay, and that the Veris that I showed you was plastic wala. This is metal Veris, but principally it is the same. It has a valve and it has an inlet. And look at the tip. This is how the tip is. It has 2 parts. There is a beveled part like this part, and inside there is a blunt tube. See properly, and the inner tube has an opening through which the air goes out. So there are 2 components. There is an outer sharper beveled tube and an inner blunt tube, and which automatically is a little anterior or further ahead. This makes it non-traumatic. This configuration makes it non-traumatic. Okay, so when I am putting it, it's very difficult for it to puncture into a visceral structure. This provides like a safety mechanism because it's anterior. Okay, and both these two things, they move aage piche. The inner part can move front and back, it's not fixed. So this blunt tube, which has the opening, the inner one, can move front and back. This is a safety mechanism of Verey's needle. It's not like a normal needle which will go through all the layers with ease. It goes layer by layer. So you know how deep you are based on this configuration of the tip. Okay. All right. This question is from Bailey. They have never asked this. I don't know why. This is from a chapter called perioperative care. Average time to return to work after lap cholecystectomy. पहले के ज़माने में when they used to do open surgery, I'll just give you a perspective. What used to happen was, let's say I'm undergoing open cholecystectomy. I will get admitted 1 or 2 days before surgery. Then next morning there will be surgery. Then after surgery, I will be kept nil per oral for a few days. Then after a few days, they'll start giving me liquids. Then I'll be discharged after a few more days. So ऐसे ही 1 week चला गया. Then I go to home, I am rest, I have pain, big lot of pain of the subcostal scar. You know, because in open cholecystectomy, they would take a incision like this, nice big incision, depending on how my abdomen is, Hawker's incision. So it would take a long time. Please understand, whenever I undergo any surgery, surgery is not removing the gallbladder. Surgery is going through all the layers of the abdomen, physically cutting everything. Everything is cut, burnt, coagulated, ligated. Inside tissues are dissected, cut. All this is trauma to the body. Okay, it's like having a big brawl. So surgery causes trauma. And whenever there is trauma, there is going to be a response to trauma, which is called as metabolic response to injury, which is called as SIRS. So your body goes into a state of inflammation. That's why post-operative, a lot of people get a little bit of fever. They are weak, don't feel hungry, don't feel like doing anything. It's not because the surgeon has done something to your gallbladder, that's why you are feeling this. It's because the whole deal of surgery is a trauma to your body. If any one of you has undergone any surgery, as little as an open hernia surgery, you will know what I'm talking about. You're not up and about, even though the surgery is a 1 hour surgery. ऐसा नहीं है कि सुबह सर्जरी हुई, शाम को मैं दौड़ सकता हूँ एंड अगले दिन से काम पे जा सकता हूँ. No, you require some period to recover. That's because it takes time to recover from this SIRS. Your body enters into catabolism. Right? You lose weight. Hernia surgery, still you lose weight. Then you don't need to come to bariatric surgery. Every surgery you lose little weight. It's because of catabolism. Response to trauma. So by the time you recover and you're up and about to return to work, it takes some time. Now you are having laparoscopic surgery. All of you have given answer 3 to 4 days, which is a little amazing to say the very least. Now when laparoscopic surgery came in early 1990s, what was the main advantage? The main advantage was your cuts are smaller, 2-3 small cuts. Okay, as the cuts are smaller, the inflammation, the trauma is much less, reduced trauma. Plus, since your instruments will now reach straight to the gallbladder, you are only handling the gallbladder. जब open cholecystectomy करेंगे, I showed you all the instruments. One person will put the Doyne's retractor and pull the abdominal wall. You will put 2-3 Deos retractors, one to retract the liver, one to retract the stomach, one to retract the small bowel. Now for a cholecystectomy, so many things are handled, isn't it? You'll have post-operative ileus maybe, and then with big instrument you'll start cut. With laparoscopy, once you are inside, you don't have to touch the bowel. Just have to push the gallbladder up, do the calyx dissection, cut everything, ligate everything, and remove the gallbladder. Trauma is significantly less. So if I'm undergoing a lap chole, When do I get admitted? If my surgery is at 10 a.m., I don't get admitted previous day. I get admitted same day at 7 a.m. 7 a.m. I get admitted. I get prepared. All the shaving is done. I undergo surgery. Surgery is over by 11 a.m. I'm back to the room by afternoon. And usually I would be discharged the next morning. Hospital stay is 1 day. That does not mean I can return to work after 3 to 4 days. मत बोलना ऐसे. Alright? Please don't say that. Otherwise, nobody will undergo lab coli from you if you give him a sickness only for 3 to 4 days. No. Still, your body has undergone trauma, but not as much as an open surgery. So you are good enough to return to work after 9 to 10 days. This is from Bailey. After open cholecystectomy, it was 3 to 4 weeks, more than double. Now it's become much faster. This protocol that you follow, getting admitted same day, lap surgery, minimal anesthesia, minimal sedation, quick recovery, early institution of orals, this is what is called as ERAS protocols. Very new. ERAS protocols. ERAS is enhanced recovery after surgery. So what they say now is, if you're doing a laparoscopic surgery, even if it's major, don't have to keep the patient admitted for too many days. Don't put too many tubes. Don't give an NEM. So when I do bariatric surgery, we follow the same ERAS protocols. जब हम sleeve gastrectomy करते हैं, and sleeve gastrectomy is a major surgery, you have to cut the stomach. We follow the same protocols. Admit the patient same day morning, operate him, start him on oral same day evening, and discharge him within 2 days. Not next day, usually 2 days. That's all the stay that is required. Again, that patient can also return to work fast. 9 to 10 days, maybe little more. It's a little more major surgery. Lap colica it is. Return to work 10 days. Remember, all of these numbers are absolutely VVIMP. Post-op protocols for ERAS. One example of ERAS they have given is for lap coli. But this can be followed for many lap surgeries, like we follow for sleeve gastrectomy, colorectal surgeries. Originally, ERAS was brought for hepatobiliary surgery and colorectal surgery. Originally, but now even other surgeries are following the same protocol, like bariatric. So what is the protocol? Start orals fast. Make him walk as early as possible, preferably discharge him same day or next day. So either daycare or overnight stay, you know these terminologies. And at home, tell him to start doing his home activities by the 3rd day, and he can return to work by 10 days. MCQ will be either this or this, in dono mein se ek. He can do home activities comfortably from when? From 3rd day. जो आप लोगों ने आंसर किया, this was actually for home activities. 3 to 4 days, he can start all home activities, cooking, cleaning and all, whatever his health permits, and he can return to work at 9 to 10 days. Clear? VVIMP, they have never asked this, but these are new things, so you need to know this. And this again is an IMP image. It's one of the complications of laparoscopic surgery that you need to identify in this case. And I'll give you a background. So this is what we call a trocar. Inside is the instrument with the active tip. It is doing some activity somewhere. And the bowel next to it is getting burnt from the trocar. So the trocar is causing the burn to the bowel in the vicinity. So what's happened here? Is it direct coupling, capacitive coupling, insulation failure, or bipolar coupling? This is a very popular topic, so I'm sure you must have heard of it somewhere or the other. कहीं ना कहीं तो ये आपको बताया होगा. Coupling injuries. Or what type of couplings? Direct, capacitive, insulation, or bipolar? You need to understand what's happened over here. Huh? So there is a trocar. Trocar is through which I put my instrument. So there is a trocar. Through the trocar has gone my insulated instrument, through it, which has an activated tip like a monopolar hook. This is the current is passing through the monopolar hook. Alright, and it's doing whatever electrocautery it is supposed to do. But there is bowel over here in the vicinity, and the current is going from the hook to the trocar to the bowel. What is this? ये समझना सबसे इम्पोर्टेंट है, यही समझना है. So you need to understand the components of this. Many of you have answered insulation failure. Gopika has said B question mark. Okay, there is nothing like bipolar coupling. ऐसा कुछ नहीं होता. Now understand what's happened over here. There is a trocar through which I put the instrument. This trocar is metal. Okay, it's a metal trocar. Inside the trocar goes my instrument. Now my instrument has insulation. Monopolar hook or whatever instrument I have used, it is insulated. And through the insulation goes the electricity inside like a wire. And the tip is exposed from where the current will go and do its job. Now what's happened over here? The electricity has gone across the insulation into the metal. So there is metal inside, there is metal outside, and there is insulation in between. In this case, the insulation has worked as a capacitor. This is called capacitive coupling, not insulation failure. So what has happened? Electricity inside, insulation outside, and metal outside, and the current has jumped from in to out across the insulation because the insulation has worked as a capacitor. This is called capacitive coupling. Insulation failure is different. In insulation failure, what would have happened is somewhere the insulation would have leaked and the current would have leaked out from the side directly. It does not have to go through the metal. It will leak out directly from here somewhere, wherever the insulation has leaked out from. That is insulation failure. That can also happen, but this image does not describe that. This image describes the metal getting electrocuted. The outermost layer. Why is it getting electrocuted? Because the insulation is working as a capacitor. So when there is two layers of metal and one layer of insulation in between, the insulation works as a capacitor. How to prevent this? You tell me how to prevent this. How to prevent capacitive effect? Answer is kind of there in the image only. How to prevent this capacitive effect? Metal, insulation, metal. If the insulation is in between two metals, it becomes a capacitor. How to prevent this? ऐसे तो कोई भी सर्जरी में होते ही रहेगा ना, ये होने का चांस है, कोई भी सर्जरी में होने का चांस है, कैपेसिटिव कपलिंग. How to prevent this? So to prevent this, don't use metal trocars, use plastic trocars. Because plastic will not give you capacitance, because plastic will also be insulated, which is given over here. ये जो collar है ना, इस पे लिखा है plastic collar. If there is plastic collar, it will not conduct. Correct? So one way to prevent capacitive coupling is to use plastic trocars. Okay. Of course, bipolar में ये नहीं होगा. This is only in monopolar. Goes without saying. That is absolutely true. The problem with these coupling injuries, direct coupling, capacitive coupling, is they are outside the field of vision. Laparoscopy का यही problem है. If anything goes wrong outside the field of vision, like this bowel is getting injured, my camera is looking over here. It will see activity over here. ये bowel कब injure हुआ पता ही नहीं चलेगा. But bowel got electrocuted. Maybe it got perforated. It will manifest later. That will be a disaster. So coupling injuries happen outside the field of vision. That is the main problem. What is the most common injury due to energy sources overall? Most common injury due to energy sources overall. Energy sources means monopolar, bipolar, सब मिला के. Most common injury due to energy sources, and what energy source should be avoided in a patient who has a cardiac pacemaker? What energy source should be avoided in a patient who is on a cardiac pacemaker? So first answer, Gopika, excellent answer is burns. And what should be avoided in a patient on cardiac pacemaker? इसका भी आंसर दे दो quickly. Should avoid monopolar energy sources, because monopolar energy or the electricity runs through the body. From the point of contact, it will go through the body, and from the exit electrode or the patient pad, it will go out. So it is actually going through the body, right? So monopolar should be avoided. You can use bipolar or you can use ultrasonic energy sources. Okay, so hope you guys enjoyed the class. This is my referral code if you are planning to subscribe. And there is a bugs bounty feature which has just been launched. If there was anything that you felt was inappropriate, you can report it. And important, tomorrow same time 7 o'clock I will be taking recent advances in GI surgery. Okay, short bowel syndrome, intestinal transplant, newer imaging modalities, newer endoscopic techniques, those kind of things. Same time tomorrow 7 p.m. Okay, so hope you enjoyed this class. Do remember to like this video, give it your thumbs up, don't give thumbs down. This is my Telegram group. If you have any doubts, Datesh wants to ask something, you can ask me on Telegram. Maybe you can message me. I won't share it on the group, but you can ask me. Maybe I can share it to you on private chat, no problem. All right, so this is my Telegram link, and I'll see you guys tomorrow same time with a class on recent advances in GI surgery. Okay, so thank you guys for joining me. Have a good day, enjoy your weekend, and I will see you tomorrow.